Recording in progress.
¿Comienzo yo? Hola, bon dia. Se'm sent bé? Sí? Bueno, benvingut.
La presentació, però no...
Ara. Vale. Bon dia a tothom. Benvinguts a aquesta Summer, a aquesta jornada d'experiència del pacient. En primer lloc presentaré els membres de la taula. A la meva esquerra la senyora Marta Belmonte Glòria, subdirectora de participació del Departament de Salut. Moltes gràcies per acompanyar-nos avui, Marta.
Moltes gràcies a vosaltres.
I m'acompanya també en Sophie Gressler, que és membre de l'equip de l'Observatori, d'Experiència de Pacients, i que ens fa molta il·lusió presentar-vos aquesta taula de medicina basada en el valor. Jo soc Olga Rubio, soc metgessa intensivista i responsable de l'equip d'Experiència de Pacient i pensava una mica com presentar aquesta taula i aquest concepte de medicina basada en el valor. Jo soc una persona molt pràctica, molt pragmàtica, i quan feia medicina intensiva, fa un parell d'anys, jo recordo que tractàvem molts pacients i que els curàvem, o nosaltres crèiem que els curàvem, i recuperaven el que seria, milloraven de la seva malaltia, però sempre teníem aquesta sensació que per ells no era del tot satisfactori aquests resultats. Aquests resultats per ells no eren el valor entès pel propi pacient. Per ells el valor és supervivència lliure de malaltia, de discapacitat, i per nosaltres el valor era guarir una malaltia. Llavors, amb aquests dilemes de què és el valor, com entén el valor el gestor, com entén el valor el professional, com entén el valor el pacient, es genera aquest nou paradigma de medicina basada en el valor i que és molt important i que a dia d'avui hi ha molts equips que estan treballant i que estan fent indicadors, i estan fent prems, estan fent proms i que cada vegada es dona més importància. No m'allargo més perquè em sembla que aquest taller anirà de tot això, i jo simplement donar les gràcies als ponents internacionals, als organitzadors d'aquesta Summer, entre ells l'Anne Sophie, que és la que ha treballat més l'organització d'aquest taller, a l'equip d'experiència de pacient, que també està aquí darrere apoyant i recolzant, i a tots vosaltres per assistir avui. I res més, dono la paraula a la senyora Marta Belmonte. Moltes gràcies.
Moltes gràcies a vosaltres per convidar-me i convidar-nos. Jo soc Marta Belmonte, com em presentaven, i soc la nova subdirectora dins de la Secretaria d'Atenció Sanitària i Participació dins del Departament de Salut. I nosaltres, acompanyats també del Servei Català de la Salut i de tots vosaltres, també creiem en aquest canvi i en aquesta medicina basada en el valor. Ja, com sabeu, és una de les transformacions més profundes i necessàries que necessita actualment el nostre sistema de salut, situar aquesta experiència del pacient al centre de l'atenció sanitària. A Catalunya aquest compromís ja es va concretar amb la creació del marc d'experiència pacient, que segurament coneixeu tots, que defineix una visió comuna i compartida per tot el sistema. Aquest marc parteix d'una idea molt clara, que és l'experiència de pacient no és un concepte accessori, sinó que és una font de coneixement essencial per a millorar la qualitat, la seguretat i la relació entre la ciutadania i el sistema sanitari. I llavors aquest marc estableix 3 nivells de treball. Un és la vivència individual de l'atenció, recollint les percepcions i emocions de cada persona al seu recorregut pel sistema, la gestió de l'experiència com a element de qualitat i avaluació, promovent l'ús sistèmic d'indicadors basats en les experiències i resultats reportats pels propis pacients, que són els prems, els proms, que comentàvem, la participació dels pacients i les famílies també, en la governança del sistema per garantir que les seves veus influeixin també en les polítiques, les estratègies i els serveis. I aquest enfocament no és només teòric, ens parla de com hem de dissenyar aquests serveis, a com els hem d'avaluar i com hem d'actuar davant dels que ens diuen els pacients, les famílies i els acompanyants. Per això aquest model d'atenció basada en el valor que impulsem també des del departament no es pot entendre sense escoltar, mesurar i actuar el que realment importa a les persones. Això implica un canvi cultural profund, com sabeu, i per això costa de fer. No n'hi ha prou en millorar l'accés o l'eficiència, cal posar èmfasi en la qualitat relacional, en el respecte, en la claredat de la comunicació, en la confiança i en la capacitat de resposta emocional i humana. I això només és possible amb professionals assistencials empoderats, formats, com els que esteu vosaltres ara aquí, i compromesos amb aquesta visió integral de la persona. Sou vosaltres els professionals qui podeu transformar cada moment assistencial en una oportunitat de confiança i d'acompanyament. Sou qui feu realitat el valor més enllà de l'eficàcia clínica. Per això és clau que disposeu d'eines, d'espais com aquest i dades útils per millorar la vostra pràctica a partir de l'experiència dels pacients. També cal que els pacients deixin de ser vistos només com a receptors passius. El marc de l'experiència pacient ens recorda que han de participar de forma estructurada i contínua en els òrgans de govern, en els comitès de qualitat, en els processos d'avaluació i de planificació. I la seva mirada és imprescindible per construir un sistema que realment respongui a les necessitats de la població. Aquest Summer School, que és una plataforma privilegiada precisament per aprendre i compartir i construir entre tots aquest nou model. Us convido, ja no vull allargar-me més, us convido a participar amb aquest esperit crític que us caracteritza, amb ganes d'escoltar i impulsar canvis, perquè només des del coneixement compartit podrem avançar cap a una atenció centrada realment en les persones i que gaudiu molt d'aquesta jornada, que aprengueu molt i moltes gràcies per organitzar-la i moltes gràcies per convidar-nos.
Doncs moltes gràcies, Marta i Olga, per donar inici a aquesta jornada. És un veritable plaer comptar amb la presència teva des del Departament de Salut. Jo anava a mencionar el pla marc que s'ha treballat, però ja ho has fet, ja ho has descrit molt bé, doncs no parlar més d'això i de tot el treball que heu fet. Mencionar-vos que avui és el segon dia de la Summer School i ens fa molta il·lusió veure tanta gent. Gràcies per venir i per dedicar tot un matí a reflexionar sobre temàtiques tan importants com aquestes, medicina basada en el valor i l'experiència pacient. Jo presentaré l'equip, com ho ha dit la Olga, que som un equip treballant en l'Hospital Clínic sobre aquest tema, i qui som i què fem. Som l'equip Observatori Experiència Pacient, hem organitzat aquesta jornada i fa temps l'Hospital Clínic va fer una aposta molt clara per situar l'atenció centrada en els pacients com a eix prioritari del pla estratègic, i això des de fa més de 10 anys. I per tant es va iniciar aquest canvi cultural, com s'ha mencionat, i és en aquest moment, amb el lideratge del doctor Joan Escarravil, que s'ha consolidat una primera part de l'equip. I també un espai físic per organitzar aquestes jornades de treball, de cocreació, de col·laboració amb pacients, amb cuidadors, amb clínics, amb tothom que sigui necessari. Doncs nosaltres, des de l'equip, ens dediquem a acompanyar els equips assistencials de l'Hospital Clínic per posar les necessitats de pacients i cuidadors al centre de tot allò que s'emprèn. I l'Observatori es crea un any més tard per completar aquesta estructura interna i pretén l'Observatori tenir una projecció més externa, més internacional, participen en xarxes internacionals, en projectes de recerca propis, participen en projectes de recerca d'altre grup de recerca també, de consultoria, oferim cursos formatius, etc. A la foto podeu veure l'espai del que disposem a l'hospital per organitzar les activitats, com he mencionat abans, i també una foto de l'equip, que no hi està tothom, de fet, perquè no és la més actualitzada, i també hi figuren companyes d'atenció a la ciutadania i de comunicació amb qui col·laborem estretament. Ja s'han dit moltes coses i serà una mica repetitiu, però anirem molt ràpid. Nosaltres tenim l'experiència com a brúixola. Pensem que el sistema no pot oferir intervenció de valor si no comprèn la perspectiva dels pacients i dels cuidadors. De fet, avui, i crec que, no sé si és la primera vegada que passa això, però tenim cuidadores en les taules, en les dues taules rodones, i volíem introduir aquesta visió també de qui cuida, una persona que té una malaltia o passa per un procés de salut. Per entendre l'experiència de pacient i de cuidadors hem d'aprendre a escoltar i a ser veritablement inclusius. També és fonamental buscar i implementar mecanismes de participació real, i això ho has mencionat, estructurades, etc., per co-crear i per innovar en la prestació de servei assistencial. No és fàcil, però ho intentem. I finalment, mesurar és necessari per saber si tenim èxit. Finalment, volem ser defensors de valors de col·laboració, d'escolta activa, de respecte i treballar per un sistema de salut més democràtic i centrat en les relacions. De fet, la paraula relacions va sorgir ahir amb una conversa que hem tingut amb la professora Alice Andrew, qui va fer aquest apunt. I ella no parla d'un sistema centrat en les persones o en els pacients o els cuidadors, sinó d'un sistema centrat en les relacions. I ho volia mencionar així perquè m'ha semblat molt interessant, aquest apunt. Ella diu que es tracta això de relacions entre l'equip assistencial i els pacients i les famílies, però també a dins dels propis membres de l'equip, etc. I que en definitiva també el que busquem és això, que el pacient i el cuidador sigui membre més de l'equip. Us presentaré el programa de la jornada i hem fet alguns petits canvis per poder adaptar-nos una mica a la realitat de les agendes de final d'any acadèmic, però són menors. Començarem amb dues ponències internacionals. Tenim dues persones que ens fan l'honor de ser avui aquí amb nosaltres, la doctora Candan Kedir de l'OCDE i la professora Alice Andrew de la Universitat de Swansea. I pensem que sense dubte aprendrem molt de les seves intervencions i que també ens aportarem elements que podem aplicar en el nostre entorn. Sempre pensem que hem de mirar a fora què es fa, perquè es fan moltes coses i aprendre de tot això, tot i que hem d'adaptar també a la nostra realitat. I aquesta primera part es farà en anglès, però nosaltres estem aquí també per fer una mica de traductor, perquè si tothom pot parlar la llengua que es senti més com per fer les preguntes i traduïm nosaltres. Després tenim una primera... Ui, havia anat molt ràpid. Ok, aquí. Perdoneu. Després tindrem això, una primera taula rodona de debat per reflexionar sobre el que ens hauran exposat i veure una mica aquí en quin punt ens trobem. Farem una pausa perquè també pensem que és molt important tenir aquest espai per poder parlar entre nosaltres i fer connexions, etc. I després tindrem una altra taula rodona per debatir, parlar del paper de la tecnologia. Si la tecnologia pot o no hauria de millorar l'experiència del pacient i potencialment també els resultats clínics. I finalment, i ens fa molta il·lusió, hem aconseguit organitzar una taula amb estudiants i residents perquè ens comparteixin el seu punt de vista sobre la jornada. Volíem també tenir aquesta conversa amb els futurs professionals sanitaris. I res més, dono pas al meu company, Joan Fernando, que moderarà la primera ponència, i us agraïm molt que estigueu aquí i esperem que sigui una jornada molt interessant i plena d'aprenentatge. Gràcies.
Bona jornada.
Molt bé, moltes gràcies per venir. Hi ha molta gent i estem molt contents creiem que el tema és interessant. From now on, we switch to English and we start with this first talk. When we started working in patient experience, there are many, many fields that can be approached, but there's one key component that's measurements. Indicators are our clue. It's said that you cannot improve what you don't measure. And if you don't improve, everything gets degraded. Don't take my word, that's the law of entropy. So a very important issue for us is how to measure and how can these measurements can get into actions that are real improvements seen from the patient's perspective. So to discuss about this, we have the honor to have with us Dr. Chandan Kendir. She's a health policy analyst with extensive experience in international health system performance measurement and comparative policy research on patient-reported outcome and experience measurements. At the OECD, she played a central role in developing and delivering the Paris Initiative, the Patient-Reported Indicator Service, the first international survey program to systematically measure patient-reported care, experiences, and health outcomes. She is the lead of the OECD's patient-reported outcome measurements work on a specific condition, including breast cancer, with that links with the session that we'll have afterwards. Candace's work is about helping decision makers to maximize health systems' performance to deliver high quality of care, and her work is grounded in the principles of collaboration and co-development, ensuring that policy and practice initiatives are both inclusive and effective. That's why we are very glad to have her here today. And she will present the key findings of the Paris Initiative and the last report. And we'll provide examples also of patient-reported measurements among people with cancer. So without further ado, if you'd like to join us.
I have a friend who really likes coming to Barcelona. And each time she comes, it's like this. This is an illustrative example, of course, but it's rainy, foggy, she doesn't feel comfortable, she doesn't want to go around and walk and do other things, and she always had a really bad experience. Whenever I come, it's like this. Look at us. Okay, it's a bit hot today, I know, but still, it's sunny. We can go around. I can walk. I can really have a good experience. And this is usually the case in healthcare as well. When it is sunny, everything is easier. Patients can find their ways easily, feel confident in managing their own health, in communicating with others, and doing other things in the healthcare system. And this is how healthcare system should look like. Always sunny, but to everyone, regardless of their conditions, situation, age, and socioeconomic status. But for many patients, I'm sad to say that it's a foggy, rainy journey to be in the healthcare system. So today, I'm going to present you this OECD initiative where we look at the international comparisons across countries and to assess whether really patients feel the sun and which characteristics of healthcare system really influence their experiences and health outcomes. So healthcare is all about the patients. This is the only reason why we have healthcare system, doctors, nurses, other healthcare professionals. But if we don't ask patients how healthcare really impacts their lives, actually most policy decisions are shot in the dark. So how we measure healthcare system today is looking at number of hospital beds, number of doctors, nurses, how many people die, how many people live with chronic conditions, but we don't necessarily know how they really experience care, what really matters to them. So why OECD works on this topic? It's an economic organization for economic cooperation and development. And what we try to do is we try to help countries develop better policies for better lives. And this includes a very wide range of topics, including health. So it's an intergovernmental organization with 38 member countries, including Spain. We do economic analysis on health and health topics. We do international data collections and comparisons. So benchmarking is the most popular thing that we know. Probably you don't know OECD, but you probably know the figures that we show with all countries next to each other. And what we try to do is by looking at this data, we try to have data-driven, evidence-based policies and policy advice to countries. And bringing together all stakeholders around the same topic, patients, healthcare professionals, legal advisors, and other related stakeholders, we try to create a forum so that we can help them solve these complex issues. So very quickly, I want to set the scene to make sure that we all understand the same thing when we talk about outcomes and experiences as reported by patients. When we say patient-reported outcome measures, basically these are validated, standardized tools to measure the health status of the patient. This might be physical health, social functioning, mental health, general health, and there shouldn't be any interpretation of a clinician or someone else. These are directly reported by patients. And when we say experiences of patients, again, validated, standardized tools, but this time about the interactions that patients can have with their healthcare professions about communication, shared decision-making, coordination, quality of care. And we have been collecting this data, but how they are used might differ. So in the lower circle, middle circle, you see at the micro level, so the practice level, in an individual patient healthcare professional interaction, we can use this for individual care. Then we can get aggregated data at the organizational level, let's say at the hospital level, and make decisions, assess the quality of care and use for quality improvement. And what we can also do is collect it at the system level, let's say the whole country or the jurisdiction, to make decisions about health policies. And this is where the OECD works then. So we are not necessarily talking about talking to patients in the individual clinic, but we are really talking about the system level, even further international level. Patient-reported experience measures is not something new. This has been collected for years by countries to measure their healthcare system performance. But outcome measures are quite new, emerging area. Here we asked countries last year what has happened in their countries over the past 5 years. And you see that out of 38 countries participated in the survey, mentioned that 30 of them had reported recent developments. Either they started discussing about problems, either they started collecting in pilot projects, or they upscaled it at national level, they collected, they reported, they used it for policy making. And 26 of them had this data collection at national, subnational, or organizational level. So one of the things that we tried to help countries was that we developed a new international survey. So we bring everyone together with the same set of questions so that we make sure that we can use them for comparison. And we assess how they are doing, but only looking at patient-reported outcomes and experiences. So we worked with patient representative groups, 10 patient associations, healthcare professional associations, policymakers, but also academics working on methodological, technical aspects to create a new international survey. In 2023-2024, we had our data collection, and finally we had data from over 107,000 primary care users, age 45 and older. This was our target population, and over 1,800 primary care practices. I'll tell a bit more about the structure of how we develop the survey, how we collect data. And you see that in Spain, over 19,000 people participated in the survey and 251 primary care practices. And we should be proud because this was the biggest sample in the Paris survey across 19 countries who participated in this first data collection, which was the pioneering work. So what do we assess? Here you see the patient level. We have patient-reported outcome measures, experience measures, but it also includes health behaviors, whether they feel confident to manage their health, and this is assessed by a patient questionnaire. Then we have another level, which is nested, so the primary care practice level, where these patients go for their usual care, and also system level, about how healthcare system is organized. And these two levels are assessed using a primary care practice questionnaire. And what we try to do is link these two data sets to see how health outcomes and care experiences are influenced by certain primary care characteristics or health system characteristics. When we asked those people, we didn't know whether they had a chronic condition, which conditions they had. The only thing that we knew was that they were 45 and older, and they visited their primary care center in the past 6 months so that they could tell us about their experiences. And what we found out is that 4 out of 5 people had a chronic condition. Half of them had at least 2 or more chronic conditions, and 1/3 had 3 or more chronic conditions. This is striking. Striking because it means that as a healthcare professional, you have been dealing with more complex issues in your daily life, seeing these patients and trying to deliver care within the resources that you might have. And what we also know about these people is that over 70% of those people with multiple chronic conditions had 3 medications, at least 3 medications. And more than 1/3 had 4 or more medications. So this also has big implications because of all drug interactions, adverse events, symptoms, the prescription practices that should be considered. So this gives us a picture of what we are looking at in terms of sample. So one thing, and we were discussing about it yesterday with John, like when you take a group picture, the first thing that you will do is you will look at yourself, how you look at the picture, like if your hair is nice, if you smile well. So I want to bring you a bit more examples, also showing you Spain, because I guess that this is where you will be more interested in looking at all country sets. So working with patients, healthcare professionals, this group that I mentioned at the beginning, we identified 10 key indicators. They said, this is really what matters to us, and this is how we can measure healthcare system performance from a patient's perspective. And looking at these 10 key indicators, we compared how countries are doing. So you have the average, of course, which is the orange line. If it's dark blue, it is above the average. If it's light blue, it's below the average based on these 10 key indicators. And this is where we see Spain. So it's basically comparable to the OECD average in 6 out of 10 indicators, and in 1 indicator above, in others below the average. So now let's look at this picture a bit closer about these 10 key indicators. So you see that on the right side, these are patient-reported outcome measures: physical health, mental health, social functioning, well-being, and general health. Then on the left side, these are the experience measures: confidence to self-manage, experience coordination of care, person-centered care, experience quality, and trust in healthcare system. Again, the dark blue is the highest values, the orange one is Spain, and the light blue is the lowest value for each indicator. And what we see is there are some areas for improvement when we look at other countries and how they are doing. And I wanted to highlight trust here, because if you look at trust and Spain, it seems like it's the highest value, but actually there was a question change in Spanish context. So while all countries were asking about trust in healthcare system, here it was measured as trust in healthcare professional. And we know that trust in healthcare professional is usually higher than trust in healthcare system. So that's the reason why you see a very high value there. But we will go into these details of trust a little bit more. What we see is that when we ask people about their social functioning, so here you look at percentage of people who report good to excellent social functioning. They can go out, they can meet with friends, they can live with their communities, with friends and family around them. And each additional condition negatively impacts people's social life. On the top, you have people with chronic condition. Then in the middle, in all countries, people with 2 chronic conditions. And there, at the bottom, is people with 3 or more chronic conditions. What is striking is that you see a huge difference between, on the left side, let's say the top performing countries, and the right side, because of the percentage of people reporting good social functioning. But also in terms of the difference. So as soon as you have one additional chronic condition, it's very likely that you will have poor social functioning in some countries compared to others. If you look at, for instance, Wales, Portugal, Romania on the lower side, you see the big difference. So people with multiple chronic conditions are less likely to report good social functioning. Well, one thing is that we cannot say that everything is related to healthcare, right? It's limited, the things that we can do in the healthcare system. But it seems like in these countries where they are performing better, there is something good happening there, so that they are able to keep at least these percentages approximately same around people with different number of chronic conditions. So there is an opportunity for learning. The second thing is when we looked at, okay, but which conditions make the difference, right? It's a thing that you have number of chronic conditions, and another thing is about which combinations of conditions you have. On the top, you see what we call concordant conditions. So this is basically conditions which share the same mechanism. Let's say if you have a diabetes, you know that it's very highly likely that you will get a cardiovascular disease and some other comorbidities associated. So these are concordant conditions, but without mental health. And at the bottom with the triangle, what you see is any combination of chronic conditions, but with mental health conditions. And we see that in some countries, the difference is again very low. For instance, on the right side, you see France, who is doing pretty well in terms of keeping social functioning for different groups of chronic conditions. But on that end, again, we see this huge difference. So as soon as you have a mental health condition, it's less likely that you report good social functioning. And we know that these days it becomes very important to integrate mental health care in primary care settings as well. So again, there's an opportunity for learning for the countries. And when we ask people about how they feel, whether they feel confident in managing their own health, in chronic care, in patients living with chronic conditions, this is highly important because most of the time they live with their conditions, and once in a while they come to healthcare center to see the healthcare professional. And what we see is that people with multiple chronic conditions are less likely to feel confident. But what we also see is that Spain is doing pretty well actually here. So people feel more confident. And what we also know is that when you receive self-management support from your healthcare professional in your healthcare center, people are more likely to have the confidence in managing their own health. And what we also found interesting here is that the gender health paradox. So what we already knew for years is that women live longer compared to men. Sorry, men, but that's the reality. That's what we see in the statistics. That's something that we already know. But what we found out in the survey is that this paradox, they live longer, but often in worse health. So the physical health and mental health of people We're always on a better scale for men than women in all countries. So here you see the absolute difference. In some countries, the difference is big. So you see in Spain, for instance, when it comes to physical health, the difference is bigger actually compared to other countries. And also for mental health, it's slightly larger. So again, thinking about this aspect of making healthcare sunny for everyone, these are the things that we should all consider. So it's not only about providing care, but also adapted to their needs, to meet their expectations and their preferences. So the question that everyone asks, what really matters? So how we can change this? What healthcare systems can do about it? And the first thing that comes to policymakers' mind is that, okay, more money, better outcomes, or better experiences. Sorry, no. So it's not the only thing which makes the difference. Here you see that there are some countries who spend more than other countries, let's say, and they have relatively good health outcomes and care experiences in the Paris survey. But what you see here is that there are some other countries who spend less, and they also have good outcomes and experiences. So it's not only about putting the money, but putting the money in a smart way, in the right place, so that you can also put this in a place where it really matters to people as well. So remember this link that I was showing you at the very beginning, that we were looking at primary care practice characteristics and also patient characteristics as well. So here you look at the average score on a scale, what we call WHO 5 well-being scale. So it measures the well-being of people on average. And what we see is that on the dots at the upper end, people who receive high level of patient-centered care on an individual level with their healthcare professional, they are more likely to have better well-being compared to those who have low levels of patient-centered care. In some countries, you see this cutoff of 50, which is considered as a poor well-being in the literature. You see that in some countries, this really goes below for those who doesn't really receive who receive low levels of patient-centered care. And in Spain, we see that this is also comparable to the other countries. And we found similar results also for physical health, mental health. So what we knew so far is patient-centered care is important, but what we know now is patient-centered care can really influence patients' physical health, mental health, and well-being. The second thing what really matters to policymakers is the trust. So trust is very important for the relationship that we build with patients, but on the healthcare system level, which was really important when it comes to COVID-19 pandemic. We were trying to get people vaccinated, respect the measures, and so on. And some countries didn't succeed with this. So we looked at trust in Paris survey, but also compared to other OECD work. Here on the top, in the y-axis, you look at trust in national government, and here you look at trust in healthcare system, and we see that actually people who trust in their government are more likely to trust in the healthcare system. So this is very much associated. But actual care experiences also matter. So we asked people if they experience any adverse events in primary care, but adverse events in the way that, for instance, they needed to go to primary care center, but they didn't get an appointment, or they couldn't book something, or there was a drug interaction which was not managed well, or they get a wrong diagnosis, wrong treatment. And what we see is that when we look at the percentage of people who trust in the healthcare system and who didn't experience any adverse events, the variation is there, but it's not that much. And these dots show people who experience an adverse event. So as soon as at the individual level you experience something that is not desirable, you are less likely to trust in the healthcare system immediately. That's a huge issue to make those people take the medicines, work with us in the way that we will ask them to manage their health, to create a care plan together. So this is a very important issue. So what we can do to build trust, relationship. I think you will also work a lot about the relationship. But what we saw is that in years, the trust in healthcare professional increases. So people are more likely to trust their healthcare professional if they have a longer relationship. So we said, okay, but let's look at this time perspective a bit different. So we run a logistic analysis, and we looked at what really makes a difference when it comes to experiences of good quality care. And we found two main important things. First, relationship with the same healthcare provider, which is longer than 5 years. And the second thing is having a consultation time of 15 minutes and more. And it was striking, the difference across countries. So you see here the consultation time first. I think this is not something striking because in Spain it's generally 8 minutes, if I'm not wrong, with the primary care professional. This is the scheduled time. And you see that in some countries like Norway, almost 90% of people with chronic conditions get at least 15 minutes for their consultations. Same for Portugal, Iceland, Switzerland, and Belgium, doing much better. But on the other side, Netherlands, Wales, Spain, we see that it's less than 15 minutes for most people. And when we ask about this relationship 5 years and longer, you also see differences here. In Czechia, Romania, Netherlands, 80% of people have been with the same healthcare professional, whereas on the other side, Spain, Greece, Saudi Arabia, 50%. I'm pretty sure that you know much better than I do, but we also know very much like the policy implications of this. International migration, people leaving the country, healthcare professions mostly, and they are changing jobs, they are moving to private sector or changing the setting to have a better experience themselves as well. So this is an important thing. That means each time there is a new opportunity to build trust, but also new resources to build trust with the healthcare profession, with the patients again. So these are like the general overview of what we see in the Paris survey. And I wanted to take a moment to talk a bit more about other work that we are also doing when it comes to comparing patient-reported outcomes, but particularly for people living with cancer. So before the Paris Initiative, we tried to launch a new pilot project to compare patient-reported outcome measures for people living with cancer, with breast cancer. People who are undergoing breast intervention and who have breast cancer at hospital settings. So what we try to do is we try to upscale what was already there, the existing initiatives at the hospital level. And it has been very limited. The only common ground that we found that we could compare was satisfaction with breast after a breast-conserving therapy or reconstruction following mastectomy. And you also see here that most of the time, these are either regional initiatives or local hospitals, groups of hospitals, or research projects who have been doing this rather than having a national initiative of breast cancer. And to do this at an international comparison level, it's a much more work, because what is really important is that what really matters at the local setting for your hospital, for the priorities of your hospital, might not be really relevant for international comparison. So that's the issue of upscaling to international level. And going back to what Paris says, because Paris was never built to be a specific condition survey, it was for anyone living with a chronic condition, not people with cancer, not people with cardiovascular disease. It was a broad evaluation. And here we see that people with cancer, they have more than 2 times different in general health across countries. So here on the bar, you see people without cancer, dots are people with cancer, and you see the difference in all countries, but also across countries. In Canada, Switzerland, it goes up to 90%. In other countries, it stays lower than 50%. So people reporting good general health. when it comes to well-being, it's less prominent. So here we'll look at the same scale that I showed you, average score on a 0 to 100, and we zoom in here, and the variation is much less prominent compared to general health. And Spain is comparable to the OECD average here. But when it comes to social functioning, it's very interesting, and I'm hoping that you could tell me why. The gap becomes very large on the right side. So compared to people without cancer, people with cancer are less likely to report good social functioning in some countries. For instance, here we see Portugal and Spain with large gaps compared to other countries. So this is not, of course, this has never been just to show how countries are doing or shaming, praising. That's not the idea. The idea is to look at the differences across countries and to see what they are really doing well, so that we can also maybe incorporate some of them in our country. So to finish, well, this was the question, does healthcare deliver? And that was the question that we used for our report at the OECD as well. Yes, it does, but only when it is really centered around patients' needs. Because otherwise we see that they are less likely to report good general health, physical health, mental health, well-being, social functioning, confidence to self-manage. So if we are not really providing it around their needs, then we are less likely to succeed in what we really want to achieve. And if we really want to make this a sunny journey for everyone, then there are some things that we can change in the healthcare system so that we can change this experience. And the first way to do is to look at the experiences and outcomes of people, because they are the ones who can guide this path to a sunnier journey, to a sunnier experience in the healthcare system. So policymakers have been talking about this for years, putting patients at the center, making systems more people-centered and so on. And in many countries, it's still just an aspiration. It's just a way to say that we are doing things for you, but they are not necessarily measuring what really matters to them. And what we try to show with the Paris work is that it's a measurable reality, and this can guide policy decisions on the healthcare system level. Thank you.
Okay. Thank you very much. We will leave questions to the floor now, but first, just to warm up, if I might, I would like to skip and just make this one. We were saying at the beginning, like, if you measure, then you can improve, and the point is to have all these indicators, all these measurements, so we can improve, right? But to link it and to put the resources on the right places, there's this risk that we are like overwhelming healthcare professionals and patients with service and more asking more of them. No? How is the OECD working with feedback, explaining the results and explaining the consequences of these results, so we can keep on engaging them and making these results actionable and turning them into improvements?
That's actually a very good question, because this was one of the reasons why many countries didn't want to join in the first place. They were telling us that their healthcare professions were already burdened with many surveys. They had other things to do, like clinical care, and same for patients. And one of the things that we implemented, we made sure that all countries implemented, and one way of doing it is putting it in a participation agreement that we sign with the countries, so that they are obliged to do it if they participate in the survey, feedback reports. So each participating primary care practice received a report from the OECD, making sure that their practice was compared to their national average, because there's no reason, there's no logic in comparing them to the international level, but you can make sure that they are compared to the national average, showing that when it comes to social functioning, this is the score that you have, this is your national average, but as a background information, this is your population. Number of women, men, number of chronic conditions, socioeconomic status, so you can put it in the context. So these feedback reports was something that we implemented like on a systematic basis in all countries, primary care practices. And the second thing was feedback to patients. This was optional, and some countries did it very successfully. So they included one last question at the end of the questionnaire asking, do you want to receive feedback from us? And they received a report comparing themselves to their national average, so that this was also meaningful for them to participate, and also you close this loop. It's not only them giving us something, but also we give them something back, so this makes it relevant for them as well. And we also knew that there were many academic work around making it relevant for patients and healthcare professionals. So if it really matters to their daily practice or what really matters to them, they are more likely to join, they are more likely to respond. So we tried to make sure that it was really co-developed, not only on the paper, but really in the room, bringing together patients, healthcare professionals. And I was telling yesterday that it's 50% of my job, basically, at the OECD to engage with academic experts so that methodological aspects are clear and transparent, but also with patients and healthcare professionals. So when they see that it's relevant for them, they are more likely to join. And one last thing to finish, the survey questionnaire for patients lasts around 35 to 40 minutes. It's a very long one for a survey like this. But the dropout rates were only like 5% or something. So when people started, this is how we interpret it, they saw that it was relevant, it was interesting, so they all completed it. And it was a really good motivation for us.
Okay, thank you very much. So now, if someone wants to...
Yes. Hi. Thank you for the speech. I would like to know if you detected, in terms of welfare state and other policies outside the healthcare system, if there were any similarities between the countries that perform better in terms of social functioning and etc. with those people that had 3 chronic conditions.
At the system level, not necessarily, because what we concluded is that till the time that you see the influence of a system level characteristic on an individual patient experience or health outcomes, it's a long way. So it was difficult to link this. But what we tried to look at was looking at the primary care systems across countries and the recent policies, what was happening in those countries, particularly those who were performing well, because this is a question that we receive very often. Why are they performing better than the others? And what we found is that they usually have a recent reform, putting really primary care at the center of healthcare and really addressing these aspects with multi-professional practices and having this long-term relationship. For instance, in the case of Czechia, they have this law which would keep the patient with the same healthcare professional unless there is a crucial reason to change it. So all these different aspects had an influence on the results, but we cannot say that you implement this program, then it's going to be all fine. You will do very well on mental health or well-being, because we also know that it doesn't work like this. It's very contextual. So one thing that works here will not work in another country. But what we try to look at is that if there is something in the country happening, and if this country performs well, yes. So they were having this focus in Norway, Netherlands, for instance, where primary care plays a central role in the healthcare system with several activities. So we see that those countries are really performing well when it comes to Paris.
Thank you.
Anyone has any other question? I can't say I wasn't expecting this one.
Thank you for your presentation. I think it's very interesting to have the global data of the countries, but it's difficult to compare one country with another one because the circumstances and the system, sometimes it's very different. But my question is, do you plan to have information over time? Because the cross-sectional information is important to have a reference, to have some, but probably from the point of view of the teams or the hospitals or the information over time could be very important in order to observe the trends or the improvements over time. Do you plan to do this in the Paris program or not?
Very short answer, yes. But before I detail it, I want to detail another aspect a bit further. So this is what we did on the international level. But all these countries, they have their national data. And they're all obliged to produce a national report out of it. So soon you will hear from Spain that they will produce a national report. And as they had a very good sample, they oversampled compared to other countries, they will also look at regional differences, for instance. So that they will have like a deeper insight in the healthcare system, which will help them, and maybe other aspects that we are not necessarily addressing at the international level because it's not relevant for all countries, but in the Spanish context, it might be relevant. So this is one thing that we are doing. And coming to your question about having these comparisons, yes, so this is never meant to be a one-off survey. So we do it now, we assessed, fantastic, and we are gone. No. This was always built as a way to measure healthcare system performance and also help countries develop it in between. So there will be a next cycle, another cycle. Some of you might have heard of PISA as an OECD work in education. Some people like it because they are performing well. Others don't like it because they're not performing well. But basically, this is what it's meant to be, a PISA for health as an OECD work. So there will be repeated cycles.
Yeah, I just wanted to ask, what has Spain done differently to achieve this comparatively large sample?
So in each country, we have this international project management, but each participating country has their own national project management team. So in Spain, there are like around 5 to 6 people working on this topic. And what they wanted to make sure that is that this regional comparison was possible. So they work with autonomous communities and with at the regional level, so that they made sure that what they were collecting from each region really reflected on the national level. So it was really their approach of involving all these regional health authorities from the very beginning. So they also advise on the survey design regarding the regional context, but also about the implementation plan. And also they got feedback about the results, so that how they were comparing at the national level and so on. So this was something they used very well, this regional aspect, going through all of them and really involving them. So the sample size from each region was good enough to make statistical analysis which were comparable at the national level.
Any other question?
Hello, can you hear me? Yeah, so my name is Alexei. I have experience working with last year in a startup. And one of the situations we have to move out from Spain to Denmark. Because our idea was to implement prompts and prems together with other questionnaires in order to make more richer the information that we can get both from care providers and patients. What I observed doing the analysis between the prompts implemented in Denmark was that some of them were took from other countries. So my question would be, if this implementation from other countries could affect the way how they were implemented in each country, and maybe also the results, because it is still visible that some countries are clustering together while others are spreading too much. And the second comment is about the men, why they supposed to be, because I remember in some of the articles there were speculations that men generally don't like to report. But if they feel well, they do. So again, another bias which might be here present, because there are no studies which did it across the Europe, for example, to have the statistics correctly done. But speculations in different articles are present. Thank you.
Just a quick clarification about the first point. So you mean taking questionnaires from other countries?
Yeah, so Danish took, for example, from UK, several of them,
Yeah.
and implemented.
Okay. This is something actually done very often in the literature, in this kind of works as well. And the idea is that because prompts and prems need to be validated, standardized tools, it's not just asking a patient in a simple way, in a way that you think it will work, in a way that you formulate, but it's in a very standardized way so that we make sure that it really measures the same thing in each country for different type of patients. So it's very standardized. And that's why it's very common to use existing measures, because we know that they are already validated and standardized. The Paris questionnaires, they are also built on existing measures. So these were coming from different countries, but not necessarily from countries, but from different research institutes, let's say, from different academic organizations. And the way that we assessed them was a whole academic process. You can find the article in the literature, Development of Paris Conceptual Framework and the Paris Questionnaires. So we did a Delphi study with patients, professionals, academics, and policymakers. So we try to assess them in terms of reliability, validity, cross-cultural validity, because this is an important aspect for the OECD work, because cultural differences can make us difference with subjective way of reporting outcomes and experiences. So we assess them on these different scales, also for international comparability. And we had a short list of instruments, and this is what we see as Paris. So it's not something that we have developed as a scratch, as questions, but a way that we patch different existing validated measures in a way that it makes sense to assess healthcare system performance system. And the second question was about men and women differences. I think this is surprising, but not that much surprising, because if you look at risky behaviors, health behaviors, smoking, alcohol, physical activity, diet, if you look at the figures, you will see that men are more likely to have risky behaviors, like smoking rates are much higher compared to women. And we also see that because of these risky behaviors, they are more likely to have cardiovascular diseases, but also develop morbidities very quickly and die earlier. And when it comes to women, so they also get chronic conditions and multiple chronic conditions as well. But because these are minimal, of course, this is not a causal relationship, but this is one thing that explains these differences in behaviors and the outcomes that we see. Then when it comes to a level that men die, women live a bit longer, but they still have these multiple chronic conditions. So they are not necessarily living in good health in terms of physical health, but also social functioning. Is there a bias in reporting? There might be. But what we make sure when it comes to sampling is that all data that we have in the Paris survey is the representative of the population, of the target population. So these are people 45 and older, primary care users. And we did this as a posteriori check. So once we had the samples, we checked with the statistics, national statistics, to make sure that it was distributed in the same way for women, men, certain age groups. So this was something that we tried to make sure that it was really representative of the population, and there was no bias that women were reporting more than men, so that they will have like a worse scores and so on.
Okay, so thank you very much, Dr. Khanna, for this very interesting talk and debate. And now we will go to the next talk, and Sophie will introduce Professor Alice Anders.
Okay, so let's continue. We have introduced the day with a very macro level presentation. Now we will move on with a Professor Alice Andrew, and she will be talking about value-based healthcare and reconnecting with patient and purpose. So we really now move on to a more macro level, because this is really what value-based healthcare is aimed at. So let me introduce Alice Andrew. So she's a senior lecturer at the Value-Based Health and Care Academy at Swansea University. And sorry, I will pronounce that very badly, I think, and the Gesell School of Medicine at Dartmouth College. She previously served as a faculty and director of education at the Value Institute for Health and Care at the University of Texas at Austin. So Dr. Andrew has international expertise in value-based healthcare education and implementation, and has led graduate and executive programs in value-based healthcare delivery, and managing teams leadership. So her research focuses on care models that prioritize outcomes that matter to patients and support the professionalism and moral purpose of the healthcare workforce. She also serves on the editorial review boards of the Journal of Patient Experience and the Journal of Health Organization and Management. And Dr. Andrew holds a PhD in organizational behavior from Cornell University and a Master in Science in the Evaluative Clinical Science from Dartmouth College. So we're very happy to have you, and please, the floor is yours.
Thank you so much, Anne-Sophie. Excuse me. Hello, thank you so much for the opportunity to speak with you today about value-based healthcare, patients, and purpose. Before I get started, I just want to mention two things. So Anne-Sophie said that I'm on the editorial board for the Journal of Patient Experience. We're doing a special collection for which I'm guest editor that I thought some of you might find of interest. It's exploring the relationship between patient experience, health outcomes, and value-based care. The deadline is not June 2025, we're extending it. But in addition to standard research articles, we're looking for patient perspectives, patient stories. And there's something called industry insights, which could be a case study, something that you're doing that's of interest. So just, I encourage you, I'll have my information at the end, and I'd be happy to talk to anybody who has interest. The other thing I wanted to mention is that I've just recently joined Swansea University in Wales, as Anne-Sophie mentioned, and it was interesting looking at the OECD results, because Wales is doing a lot of very interesting work, but they're at the bottom of a lot of the outcomes. And I think maybe the answer is that they need more sunshine, because that's something they don't have, and clearly sunny's better. And I shouldn't joke, but they really are doing interesting work, and I'm excited for the next time that they're looked at to see if they do better. But here are these QR codes. This is a learning needs assessment we're doing to find out what do people want to learn about value-based care. And so if you're interested in completing this survey, it will be open for a little bit longer. And the other is a link to the education we do in value-based care at Swansea. We have both a MSc program, there's a doctorate, a DBA, and an executive education online and in person. So with that, let me just share my agenda for today. So I'm going to start out talking about how I see value-based care, because it often means different things to different people. Talk a little bit about outcomes and thinking about how we measure what matters. Then talk about experience. How does that fit in? And how does experience help us achieve the best outcomes? And I'm going to close talking a little bit about health professionals and how we need to build relationships to transform health and care. So in healthcare, everyone has a story. And I want to share a bit about how I came into this work, because it ties into what I want to talk about today. So my background is organizational behavior and management. I'm particularly interested in the connection between value-based healthcare and the engagement and well-being of our healthcare workforce. Pre-COVID, but particularly post-COVID, at least in the US and the UK, we have a real crisis in healthcare. Clinicians, administrators, nurses, people are leaving the field. They're burned out. There's moral distress and moral injury, and a sense they're unable to do the work that they came into healthcare to do, which is to help and to heal. They're burdened by administrative things and other things, and they're busy with this and that, but it's not necessarily focused on the patient. And just a personal story, I have a brother-in-law who's a physician. He's a general practitioner. He's smart, caring, thoughtful, and dedicated to the healing practice of medicine. Well, he retired about a year ago at age 65 from his role as a high school physics teacher, that's secondary school physics teacher, in a lower income area of the United States. He left medicine about 20 years ago. He saw what the future might bring, and he wanted to take care of his patients, not be their business manager. Sadly, he was ahead of his time, but he's not alone. The stories of healthcare are about both patients and professionals. So why, in something so important as healthcare, do so many problems persist? It's not lack of attention. We have shared goals, vitality of life, and dignity of death. We have smart, hardworking professionals who are trying to make a difference and sacrifice often a lot of things in their personal life to be in this profession. Yet healthcare outcomes remain highly variable, costs are increasing, and innovation often happens very slowly. And we have huge inequities and growing health disparities. And no matter how we're funded in terms of our countries, we need to figure out how to serve more people more effectively and often with fewer resources. So I think that we often get sent off in the wrong direction because of a tendency to assume that healthcare equals treatment rather than care that achieves health. So I like to think of healthcare as two words, health and care. Treatment is not the goal. People are seeking solutions that improve their health outcomes. And again, the purpose of healthcare is health. So in other words, and I've seen some other similar imagery this morning, we need to reset our compass, the North Star of healthcare. The goal of healthcare is better outcomes for individuals, families, and populations, the results of care. Now, admittedly, especially after seeing Dr. Kender's presentation, it feels a little uncomfortable and maybe a bit bold to be an American standing in front of a European audience talking about healthcare transformation. After all, the US spends more, we're like up in that nice quadrant there for the spending, and we achieve less. According to the OECD report, the US spends 17 to 18% of GDP on healthcare compared to the OECD average of 11 to 12%. Life expectancy, 76 years compared to the OECD average of 81 to 82 years. And many other statistics show the US is behind many high-income countries. And frankly, given the state of the US right now, things are going to probably get worse, a lot worse. So despite differences in our costs and our methods of funding, we all share concerns about whether or not we're improving health. There's a recognition, and I think that's why many of you are here, that you recognize that we're paying for what's done to patients, not what's achieved with them and not with what we can achieve for our populations. And I think value-based healthcare can provide a path to get there. So when I talk about value in healthcare, I'm talking about the health outcomes that matter to the patient over the cost of the full cycle of care. And you've probably seen this equation before, but I'm just emphasizing it's outcomes that matter and it's cost of not just the little procedure, but the full condition. I've also put a delta here to symbolize change because not everybody's going to run a marathon after their health care. But we should know, have you improved to where you expect given your baseline? Also, if we treat lots of people who don't need it, who are healthier, in other words, if we give low value care, the overall outcome might look quite good, but the change will be minimal at best. So the change in health outcomes over the cost of the full cycle of care. And I'll talk about patient experience in a bit. I want to emphasize I absolutely believe it's important and has a profound effect on outcomes. I also want to say that sometimes the way we measure patient experience isn't enough. If you have a wonderful experience in terms of you're treated with dignity, clearly important, the rooms are nice and the food is good and you can park, doesn't matter if you don't achieve the health outcomes that you want to achieve. So we often hear value talked about as cost, ignoring the outcomes. The word cost can be controversial. I've been told often by people in Europe and other countries that have single-payer healthcare or universal that cost is only important in the US because of our crazy payment system. So it's about rationing care and profit maximization and assessing risk. In Europe, we have universal single-payer healthcare, so cost isn't a concern. But of course, the actual cost of delivering your healthcare, the cost of inputs like the supplies, labor, infrastructure, medications, should be of concern. If you can deliver better health outcomes and reduce those costs, you can help more people and better serve your population. So no matter our systems of care, resources are finite and getting tighter all the time. On the other hand, if costs were our only goal, we could just provide painkillers and compassion and let people be on their way. That would be very inexpensive, but that's not the goal. It's not enough for healthcare to be cheaper. Healthcare is about holistically achieving better health for more people. So here's an analogy. You don't fly for fun on an airplane for fun. I mean, maybe you do, but most people I don't think do. And few people seek healthcare for the experience. I mean, imagine if your pilot said to you, we're on time, turbulence-free, and the snacks are complimentary, but we're not sure where we're landing. If you need to meet in Paris, a cheap plane ticket to London or Geneva isn't the solution you need. Similarly, healthcare needs to achieve the results you need. So what are these results, the outcomes? We've talked about the detailed outcomes in the OECD report, which are very important for creating validated measures and being able to compare. But how generally can we think about what matters to patients? What is health? So in several decades of talking to patients, my colleagues from Texas, Elizabeth Teisberg and Scott Wallace, also colleagues from Dartmouth, have found that outcomes that matter tend to fall into three broad categories: capability, comfort, and calm. So capability is doing what makes you you. If you have diabetes, can you use your feet? Now that may be somebody who wants to walk long distances or somebody who wants to be able to play with their grandson. It might mean different things to different people, but it's all about that capability. Comfort is about the relief from anxiety and depression and things like that that go along with having healthcare treatment. And then calm is, can you live your life while you have your condition? Can you work? Can you take care of your household? Typically, if we measure actual patient outcomes and we're using PROMs, they tend to fall into that first category of capability. So it's what we think of when we talk about patient outcomes. So usually the medical outcomes related to patient goals, and they're important. The second, comfort, is assessed occasionally. We use depression scales sometimes or other mental health indicators when patients come for treatment, although in my experience, we often ask the questions, but then they're sort of put away. They're not used in treatment. And patients fill out more questionnaires and surveys for nothing. And that can be worse than not asking at all. The third area, calm, is often underrepresented or an afterthought in care. It's asking, does life go on? Are you spending all your time going from doctor to doctor? What's the burden on my family and on my life? And I want to share an example of how these things fit together. So this is Dr. Shannon Jackson. She's a professor at University of British Columbia and a hematologist at St. Paul's Hospital in Vancouver, Canada. She was a student actually in our master's program in Texas, and she just does really amazing work. So she learned, because she was measuring it, that she had a high rate of no-shows for men with hemophilia. They weren't coming to their appointments, and she realized also that her outcomes weren't as good as others in Canada. Now, talk about trust. In Canada, and actually in the US and probably other places, there's a long history of no trust in the healthcare system among men with hemophilia, because there was a tainted blood scandal and other cover-ups around that led to these men contracting HIV and other infectious diseases. As a result, there's been typically a high distrust in the medical system. Many of these men manage their conditions on their own or with their families. They weren't doing prophylactic treatment with clotting factor to help them prevent bleeds. Instead, they were just trying to manage their active bleeds. Their primary medical relationships were with blood banks, because that's where they got the clotting factor, And if they needed medical care, they'd see a GP or somebody who didn't have deep expertise in hemophilia. They didn't want to travel to St. Paul's Hospital because I don't have a map here, but Vancouver's at the bottom of British Columbia, and it's 2,500 kilometers, right, to the very north. And there are fewer people up north, but still the travel region is just gigantic. So they live far away. The clinic space at the St. Paul's Hospital was small and crowded, and men often waited hours for their appointments. Overall, the clinic environment screamed, patients aren't important. And when they were seen at St. Paul's, the attitude was a little bit like you might use with your children if they're not paying attention to you. So as Dr. Jackson looked into the root causes for the no-shows, she discovered a lot about her patients and what was important to them. And I just want to share a quote. She said, before it was a lot of finger wagging, so like this kind of thing. I don't know if that's typically you might do to your kids. Things like, well, how many bleeds did you have? And why didn't you do this? And here's some work for you to do. Do better next time. But patients were telling me about trying to get their kids out the door for school and having to get up for work. So I got an appreciation of what I was asking them to do, what I was wagging my finger, and why they were saying it might not work for them. So she recognized that she needed to understand the voice of the patient and how it affected their outcomes. Eventually, she created a team that included the physicians and the nurses, along with a physiotherapist, a nurse practitioner, a coordinator, a social worker. I know that many of you are working on team-based care here. The team worked together to make significant changes. They invested in learning motivational interviewing aimed at helping them talk to their patients about their lives. It wasn't really something they were trained to do clinically. They needed other training to help them do that. And asking patients what got in the way of their care. They helped their patients time the prophylaxis, taking the clotting factor according to the rhythm of their lives, such as helping athletes identify where and when they might be vulnerable to bleeds. The team started doing point-of-care ultrasound to assess joint damage to further help them and the men understand which activities led to bleeding. It was very much a shared understanding of working with the patient to help figure out how can we make this work for you. And they also started a telehealth program so you wouldn't have to travel all those kilometers every time you needed a visit. And importantly, they measured. They measured the results and they adjusted treatment. No-show rates dropped dramatically. Patients developed relationships with the team members and the providers with each other. In fact, the blood banks that provided the clotting factor would let the St. Paul's team know if they heard one of these men talking about going in for surgery, because it's very complicated to do surgery on a patient with hemophilia. And St. Paul's would reach out to the surgeons to help them manage that process. And overall, their patients went from an average of 13 bleeds a year to an average of less than 1, and it's sort of approaching 0 all the time. The men had less chronic pain, they had greater life expectancy, better relationships with their care team. I mean, everything they could live their lives, capability, comfort, and calm. Dr. Jackson talks about they went from men living in bubble wrap, the stuff you put packages in that you can pop, just all protected, because that was sort of the initial focus, to actually living their lives. And the clinician's understanding of the patients changed too. They moved from thinking about managing this illness as, well, you get a shot, to focusing on how prophylaxis fits into these men's lifestyle. And fundamentally, they built relationships and lines of communication. And that's part of the essence of value, creating relationship-centered care. Relationships between patients and providers, but also among the clinical team surrounding the patient. So just sort of looking at this all together, Dr. Jackson found a gap, high no-show rates, and suboptimal outcomes. They took the time to understand the why, what mattered to patients. They designed the care around patients' lives. They measured the impact, and then they made changes to keep improving. And they shifted their perspective, what Dr. Jackson called from deficit-based to relationship-centered. So no more finger wagging about compliance and saying, you're bad, you're wrong, you're not doing what you're supposed to do, which is the deficit approach, there's something wrong with you, to let's do this together and build relationships. So now this is how Dr. Jackson approaches her work, which these days involves changes at the healthcare system. She starts by understanding what matters. And I was at a conference a couple of weeks ago in Montreal, and she put up this slide to talk about some other work she's doing. And essentially, you have the providers on one side, the patients on the other side, and the gap in the middle. And she's working on how do you close this gap between what healthcare providers think and what patients want. And she actually talked about how you can't just sort of throw another prom into the system, how you have to take the time to learn from patients about what for them is capability, comfort, and calm. And this is where patient experience becomes really critical. So too often, experience is measured as how were we? How is the parking? How is the food? Was your doctor nice to you? These are all important, but they should be the floor, not the ceiling, not what we're trying to get to. The question should be, how are you? Are you better? What gets in your way? So experience shapes how are you, and knowing what matters starts with patience. You have to understand experience to understand how are you, but it's a deeper understanding of experience, so it's not just how are we. So how do you get that deeper understanding? First of all, you have to speak to patients. And I'd argue that co-production isn't enough. It's great to involve patients in the process of care redesign, but you often get a very engaged and activated group of patients, which is great, but you might not be hearing all the voices. So you need a deeper understanding of patients and of the different segments of patients with a similar medical condition. So methodology, again, developed by my colleagues Scott Wallace and Elizabeth Teisberg, they call it experience group research. It's a lot like a focus group. The goal, though, is to understand what makes a good day in your care. What brings you hope? What gets in your way? You can do this in an individual conversation or maybe even in a survey. But when you have a group of people that you bring together with a shared medical condition, they start talking to each other. And they share their hopes and their fears and the details of what made their experience good or bad and how it affected their outcomes. You'll also figure out other segments of patients within this medical condition that we have to separate, even if technically they have the same diagnosis. They may need different solutions. So, kind of obvious example is early stage compared to late stage cancers. The experience of care at these different stages will affect outcomes. So let me share another example. These are, again, some of my former colleagues from the University of Texas. I'm Rebecca Shear and Rebecca Munoz. They formed an organization called Polaris Global Health Solutions to help others gain a deeper understanding of patient needs and outcomes that matter. They've done a lot of work in oncology, and now they're actually doing quite a bit of interesting work with a group that's developing a retreat focused on survivorship at different stages. So Rebecca Munoz was diagnosed with breast cancer at age 29. She started to explore the challenges facing young adults with cancer, and I understand there's work going on here around this as well. And recognizing that, in her words, they often were caught between two worlds, services designed for children and those for older adults. And she describes it as that stage where you don't look old enough to be sick, but you aren't a pediatric patient. So some of the concerns she expressed, she almost didn't get a diagnosis. She found a lump in her breast and went to her gynecologist, and the doctor's response was, "You're too young for cancer," and only referred her for a mammogram after Rebecca detailed her extensive family history of cancer. So it took a while, and it might not have happened at all if she hadn't been persistent. Rebecca reports how her concerns were repeatedly minimized during her treatment. For example, she asked about cold caps that are used to help preserve hair, and she was laughed at by a nurse. Actually, that activated her to start some of this work. She went on, actually, she recently got her doctorate, and she started a group called Chemotherapy Cold Cappers that has reached several thousands of people to help them do this if they want to. And Rebecca talks about how the hair, it wasn't about vanity. It was about self-perception and identity, particularly at her age, and wanting to see herself as a young, vibrant woman who was living a life with cancer. So Rebecca began doing experience group work with young adults with cancer, and some of what she learned are things like fertility conversations that happen later, not at all, and that's pretty tragic but irreversible. Experiencing clinicians dismissive of symptoms or other concerns of these people, no one to talk to about the issues around identity and having cancer at this age. How do you think about dating? How do you think about your social life? Mental health issues, issues around social isolation, and then how do survivorship needs for this age group differ from kids or older adults? And those are just a few of the issues. So Rebecca's obviously not alone in looking at this, but even now when these issues of young adults with cancer are talked about much more often, there aren't usually services to support these young adults through their care journey. And as such, a solution to achieve the best outcomes really has to be different for young adults with cancer than for children or older adults at a different life stage. The environment of care can't be the same. So the other person on here is Becca Shear, who had worked at the Livestrong Cancer Institute before she came to the University of Texas. And she was really instrumental in doing a lot of work to shape cancer pathways for young adults at the University of Texas. And one of the reasons the work at Texas was innovative at the time was at a brand new medical school where they were really trying to do things differently. So there was a lot of opportunity to bring in these ideas. She actually worked with, you don't read this, it was just an article about, she worked with the design school to help think about what would a physical space look like for these young adults with cancer. It's a place where it didn't feel too babyish or too old. And they had ideas that, could we have something that's like a juice bar with the person who's there, sort of quietly observing and being able to reach out and help people when they need it. Getting a sense of their mental health. So at this Montreal conference I mentioned, I moderated a panel of patients who were young adults with cancer. And one was a young woman with ovarian cancer who spoke about the infusion suite and wishing there was someone like her there that she could talk to. So in experience, the physical space matters as well. Earlier, I mentioned that, I talked about value in terms of air travel. You care about where you're going, the outcomes, and said experience is important, and I'd get to it later. Well, it's clear that outcomes don't happen in a vacuum. So let me switch metaphors for a moment. Think of outcomes as the fruit we're trying to grow. An experience, it's not decoration, it's the water, the sunlight, and the soil. You don't water plants to be nice. You do it because otherwise nothing grows. So experience is incredibly important. And experience and outcomes go together in thinking about how do we provide the best health delivery solutions. So the last thing I want to mention here is about health professionals. I started out saying this is a real concern of mine. We can't achieve the outcomes that matter when our health professionals face burnout and moral distress. And a benefit of value-based healthcare is focusing on what's right for patients, on the outcomes that matter, and the experience environment we need to get there is that we return healthcare to its goal, to its purpose, which is helping people lead their lives. Aligning with purpose is an antidote to moral burnout, because it's why clinicians came into healthcare, like my brother-in-law, in the first place, to help people. Working on relationship-centered learning teams provides opportunities to work at top of license and to really engage, like Dr. Jackson's team at her bleeding program in Vancouver. And in fact, I want to share some of a longer quote that Dr. Jackson shared about the role of meaning and purpose in clinician engagement. So after 2 years, this is from her words, after 2 years of a new management structure that had been put in place to improve efficiency, I'm sure some of you have been there, I wrote a resignation letter saying the current structure couldn't meet the minimum standard of care. Too many patients weren't getting the care they needed. I brought the letter to work that day, thinking about my disillusionment with a system focused on the wrong things. But then a patient, someone with terrible bleeding outcomes who didn't like to come to clinic, told us he wanted to try the new preventive approach we'd been suggesting. His goal was to go to the beach with his partner and his dog without fear. The conversation was a turning point. A few months later, our outcome data for this preventive approach showed a dramatic decrease in bleeding rates for most patients. It was joyous, she used that word. These changes in the clinic and with patients changed how the team responded to each other. Everyone was working incredibly hard, but with a collective, clear purpose. What we were doing mattered and changed lives. The resignation letter stayed in my bag, and I eventually discarded it. Value in healthcare can change patients and professionals. So in summary, the goal of care is health, not just treatment. We need to reset the compass and design care around what people need to live their lives, not just what we do to them. Outcomes that matter are all of capability, comfort, and calm. They're not extras. They're what people hope for care, would allow them to lead their lives, and they must be measured and pursued intentionally. And while experience isn't the goal, it's the environment that enables outcomes. Again, we don't water plants to be nice. We do it because we need things to grow. Experience matters. And finally, value is about focusing on the purpose of helping those we serve and supporting the professionalism of those who serve. Thank you, and that's Welsh for thank you.
Thank you very much for the very interesting talk. So we have time for questions. Are there any questions in the room? So we'll do as Joanne has done before. I will ask you one question. I have two actually, and I'm not sure which one to choose. So I'm going to throw the two, and you can pick up the one that you like. So I wanted to. So you mentioned how experience is important and how it might be difficult to reach everybody, and especially so the most vulnerable group maybe. So people that might have a worse outcome or worse experience. So how, or what would be your recommendation? How can we do that to really make sure that we capture the experience of everybody, and we work mostly for the one that really needs it? And the other question, because maybe you can link an answer around those two, is around the payment mechanism as well that is linked as well to value-based. So I know it could be another entire talk, but just maybe if you can do a quick mention on within value-based healthcare, how it links to payment system. Thank you.
So so patient recruitment is going to vary everywhere. What is going to get people together? But I think the main point that I was trying to say is trying to seek out groups of patients rather than just the people who come to you or volunteer and are maybe involved in your conversations. Of course, those perspectives are completely important. And those may be people you can use to help you reach the other people. But just that magic, I mean, you've done focus groups with patients, right? When you see people together having the conversation about what matters to them, the interviewer fades into the background. People start having conversations and really sharing things that they might not share in a one-on-one conversation with a clinician or a researcher who's leading that. They sort of forget that they're in that environment. And we've actually seen relationships built afterwards, people exchanging phone numbers and things because they want to talk about what matters to them. But that's the beauty of the group, and just of trying to think about who are you not reaching. So in Texas in particularly, you know, we're all English speakers for the most part, but a lot of the population are Spanish speakers primarily. So doing groups in Spanish, going to communities, having community organizers help us find the people to do that. And again, the context will determine how you do that, but it's important to do. Payment is gigantic for sure, but I don't think anybody's got it quite right yet. Certainly in the US we don't. But just when we think about incentives, and the incentives change depending how you're funded, but what are you rewarding people for? Are you rewarding them for how many procedures you do? Are you rewarding them for treating a condition, say, you know, you have payment that's based on a knee pain over the course of a year. It doesn't reward you for getting a surgery. It doesn't reward you for not getting a surgery. It is, the payments are determined, there's patient risk, but on thinking about what's the right cost to treat this person for a certain period of time. I don't know that I would have time to go any deeper than that, but happy to talk to people separately. It's and in Europe, where you have universal and single payer healthcare, you know, all the systems are really different, but the potential for doing it, I think, is a lot stronger because the incentives are different. And I mean, one of the big challenges in the US is if you help people stay out of the hospital, hospitals lose money because the patients aren't coming back, right? And so that's perverse incentives. So they're not the right kinds of incentives for creating healthcare around health.
Thank you very much. So I think we can move on maybe with the next panel, because actually the idea of the next panel is really to react upon what has been presented by both of you and keep the discussion alive. So we might have questions from you after. So I invite, well, my colleague Brittany, she will be moderating the panel, and the three panelists. And thank you very much again for the...
Okay, so good morning, everyone. So as Anne-Sophie said, we're just going to be building on the discussions that Dr. Andrews as well as Dr. Kender, they have had, the presentations that they have done. But we're going to be focusing more on a macro level, looking at the routine integration of PREMs and PROMs into clinical practice, focusing on beyond just checking a box to tools that really create impact, to tools that are able to, help us with decision making at all levels, tools that can empower patients and, just overall improve care. We're supposed to have three panelists. One should be joining us virtually, but next to me I have Dr. Lucia Kasarova and Dr. Ivan Victoria, and we're supposed to be having Dr. Sunyol as well. She's here, okay. So I'll start with the two panelists next to me. So Dr. Lucia Kasarova, she is a social entrepreneur and healthcare specialist, passionate about improving the quality of life of people and services, especially children and young people. She's also a parent to a child with chronic conditions. She splits her time between the charity she co-founded 20 years ago that works with children in foster care and improving the quality of healthcare services and the experiences of patients. She has a PhD in health policy from the London School of Economics and has worked at the World Bank, the Nuffield Trust, and in healthcare consulting. She believes in real good, not only feel good, in other words, about bringing truly positive change in the lives of people. She enjoys getting engaged at the micro level, but also tries to achieve larger scale system improvements through research and better health and social care practices and policies. So that's Lucia. Then we have Dr. Ivan Victoria. So he is a medical oncologist trained in the Hospital Clinic of Barcelona. Afterwards, he joined the clinical trials unit at the hospital clinic as a specialist. Initially, he focused his work on treating patients enrolled in clinical trials in advanced stages of development. For the last 10 years, he has been part of the early phase clinical trials team, specializing in the management and treatment of patients, including in phase 1 and 2 clinical trials. He combines this responsibility with his role as clinical coordinator of the clinical trials unit for oncology and hematology. And then we have Dr. Rosa Sunyol, who is behind me. So she is the president of the board of trustees at Avadis Donabedian Research Institute. I hope I pronounced that correctly. She is senior researcher and senior lecturer. She has been part of the Paris SOAR consortium, supporting methodological development, implementation, and analysis of the project. She is Deputy Director of the International Journal for Quality in Healthcare since 1991. She held the Donabedian Research Chair in Quality at the Faculty of Medicine at the Autonomous University of Barcelona and served as a member of the JCI Accreditation Committee. She has led several EU projects in patient empowerment and self-management. She has over 30 years of expertise in research and implementation of quality improvement in healthcare and social care. So now that we have gotten to know our panelists a bit more, I think we can just jump right into the discussion. Also, it will be quite dynamic, so you can keep your questions, and I think towards the end, there will be, space for Yeah, and Sophie will pass the mic around. So we have quite a multidisciplinary panel. We have a caregiver, we have a medical oncologist, and we have like a researcher. So based on your background, the question is, what opportunities do you see for the routine collection of PREMs and PROMs in clinical practice to improve care delivery? You can start.
Should I go first?
Yes.
So I had my answers prepared, and then I heard Alice, and then I heard Cannon, and as you said, everyone has a story. And I went through my entire story as a health specialist, as someone who was passionate about improving things, to then becoming a carer. And then I went through it all over again. And in every single encounter I found myself, this was in the UK, I thought, I'm trained in the field, and I struggle. You know, how is it for everyone else, all the other children, young people, and the families? So things have been said, the things I prepared, right? That you need PROMs and PREMs because they help you focus on what really matters to patients, us, families, not just the clinical outcomes, the questionnaire, to see the person with their entirety, that they have lives beyond those visits, beyond those X visits. Doesn't matter how many conditions you have. It could be every few months, or you could be going every single week. But I think probably the best comparison is that Alice said about going from the bubble wrap to actually feeling activated and living your life with the condition. And that means, as a carer, you know, you think, okay, you're just kind of around there, but it's everyone's daily life, school, work that's impacted, in addition to the visits and the encounters. So when you first start, it's a shock. It's usually a traumatic event for most people. And you need time to cope, and you need help to cope, to be empowered, right? So, but then I go back to what Cannon said, that usually it's a rainy experience. You're not at all empowered. And I, as a professional, had to go part-time in my job because I was coordinating the care of my daughter, and we adjusted every single thing in our life to be able to live and cope. And it's not a sprint, it's a marathon, right? So you need to readjust everything to be able to, you know, they have this other measure called the patient activation measure, when you are where we are today, right? Living our lives, and it's one bit in our life. But I think that should be the goal, you know, to think, not what we experienced either, but that the team is wrapped around you. And it's also what, and the opportunity, so to answer it, because I think we'll speak a bit longer, but PROMs and PREMs, you said it's the ground floor, but often we don't have that, right? So we don't often have the ground floor, and often we're repeatedly asked questions. And in research, it's done a bit better. They explain, and again, I'm a researcher and an expert in the field. So you say, okay, I understand why I'm filling this out, why I'm coming to the focus group, why I'm telling you what we need, what is difficult, how the ideal would look like. But it's very rare that it comes back to you, what has been done. From research, maybe you get the results, but all the other times, you're either not asked or you don't see what's changed and what's improved. And I think Alice said it right. Don't ask me 10 times if you have very limited capacity to change. So I think the part, and I use this example a lot, others have heard it. This was in a small hospital in London, where on the board they said, you said, we did. I mean, it was very, very basic. But at least you felt that if you're asked, and whether now it's PROMs or PREMs, then that data is used and something changes.
Well, it has been a wonderful answer, so I don't think I can get like that. What I can do is to provide a little bit of my experience, my opinion on clinical research, and as medical oncologist as well. And from my point of view, what can PREMs and PROMs add to the visits? I think that it can help to set some goals. We have been used to evaluate how treatments work depending on if they are able to prolong survival or how much time can you be on a particular treatment. And fortunately, from few years, we are evaluating if that treatment can make a change in quality of life. So it's not something that you use normally in your routine, in your clinical assistant routine, but it has been implemented in clinical trials. And not just that, but after you perform the clinical trial, and fortunately in this randomized trial, when you compare two treatments, the one that you already use and a new strategy, and it happens that the new strategy provides some prolonged survival or time on treatment, and it's approved by the regulatory agencies. There has been an initiative by the ESMO, the European Society of Medical Oncology, by which they evaluate those treatments, not just from the point of view of overall survival or progression-free survival, but if they can provide increasing quality of life, or the toxicities are tolerable. So from that point of view, they do a comprehensive analysis that provides another view that even the countries and the agencies use to decide if they can afford those treatments or not. So going back to the way I started, I think that knowing with more detail what are the patients expecting from a treatment, which are their goals, it's a conversation that cannot happen on day one. It's something that you have to build over time in the different visits, and questionnaires may help to gather that information, especially because it's not a fixed picture. It's something that may change over time, and your priorities one day may change next month. So I think that having those questionnaires as part of daily routine in clinical assistance may help, may aid the objective of setting goals that work for patients.
Okay, thank you. Dr. Sanyol?
Yes. I think I have to say that beside my role of researcher, I have been a clinician practicing medicine, family medicine, for 30 years. And I think it's important to say that PREMs and PROMs are used differently in clinical practice than in policy making. In our daily practice, I think all doctors and nurses used to ask patients, do you have pain? How much pain do you have? Can you breathe well? Do you feel sad? So I think these type of questions, and even better if we can use standardized questions, that there are some of them or a lot of them, can be used to evaluate clinical practice. And I think perhaps it's not very relevant for research purposes, but extremely relevant for handling the patient. If I have a patient that can climb 3 stairs, it's quite better than if you have a patient that cannot climb that. So if you agree that this is it's also a priority. So I will tell the clinicians in the room, start doing it. Whatever is or is scientifically or not scientifically proved questions. By the way, if you go to the questionnaires of the Paris questionnaire, most of them, the PREMs and PROMs, are validated questions, mainly for policy issues, but also some of them for clinical issues. So you can start selecting some of them, or at least exploring some of them. When it's an issue of evaluating a treatment, as you were saying now, or evaluating a policy, the situation is different. Of course, you need to have a sample, you need to have a standardized questionnaire, but still this is very important because it can help us to see some of the issues that we have seen today in the presentation before, seeing that patients having more trust, have better situation of feel, perceive health, these type of things that make changes in the health system. But I would just like to keep it back to the daily practice and saying, you can do that. I mean, I think it's important to ask the patient what is important to you in the next 3 months, and try to explore this type of prems and prompts that they could be important for them. And different measures can at least give you an idea, not very scientific, not published in the BMJ, but clinically very relevant and vitally very relevant as well.
Okay, thank you. And so, like, what I get from what you guys have said is that prompts and prems can be truly relevant in terms of, like, setting priorities, truly understanding what is, you know, relevant to patients, what they think is important. And Lucia, you made a very important point about, like, explaining to them, like, the value of these questionnaires, why we're using them. So I think my follow-up question would now be, okay, we've, like, identified the opportunity, but what, like, hurdle, how do we reach to this, you know, point where, you know, it's truly integrated? What hurdles do you see that we need to overcome to get here?
So I'll speak from the personal experience from going across different healthcare settings. I think the hurdle is data collection. I think we can learn from the airline industry or the private sector. I mean, I think you get it through papers in the wrong time, through some clunky portals. It's not explained why they're collecting, what they're collecting. Never have I come across that we've filled in something, and then maybe during the visit, it would be pulled up, or you say, well, you know, Lucia, your guys' experience seemed to have been this. Look, we see this, does this reflect that? And I could say, well, that's a year old. You know, in the meantime, as you have said, our priorities have changed. We have gone through another whole roller coaster. So I think that is probably one of the challenges, that we need to be where, now I'm mixing hats, but where the patients are, I like to say, right? We spend hours in the waiting room. I have tons of time to fill in things, to answer, to click, to see something you've done, right? That time is not used, and then we're trying to get the patients when maybe it suits, and that goes back to Alice's perspective, right? Like, it's teamwork, it's relationships. We understand the realities of the doctors as well, right? So maybe they finally have time for us. So it's, you know, now they send us something. And I think it's coming together. And I think the models, or where I've seen that it works, that we share a lot, we exchange, the relationships are there between us and the medical team. But usually, and I want to really credit your work that you've done from the OECD, that you actually went back to the countries, you went back to the practices, you asked patients the option, would you like to see results? And because that was one of the questions after I was preparing for this today, I'm like, I wonder if any of this goes back and if they ever hear, because from a policy perspective or as an expert, I understand, you know, we want to look at trends over time, compare the countries. But if the patients can benefit from this, and if it's a continuous process, and ideally if the doctors and the local providers can react and work together. But yes, I think probably the hurdle is around explanation of what, why, what will be done with that, and then making it easy.
I would say that the most important one would be the lack of time during the medical visits. We have to keep in mind that the cancer incidence is increasing. The complexity of the different approaches, at least on my field, it's getting more and more complicated. We have to take into account clinical aspects, molecular aspects, different treatments that they're becoming more and more complex. The time that you have to treat patients accordingly, to understand, to really get to the bone of what they want and to adjust yourself to it, it's a problem. Obviously, there's a lack of knowledge on how to use them properly. I've been raised in a way that the patients needed to adjust themselves to the way the doctor used to treat them. Fortunately, it's something that is changing, and we have learned how to adjust ourselves to the patients, but we have to adjust ourselves as well to which goals they want to reach, which are important. We have to remember them. We have to be ready to adjust them over time. So that takes time, and all those questions takes time as well, and you need to feel that it makes sense to do those efforts, not to make those efforts to get more valuable information. So with a little bit of more time and a little bit of more knowledge, and to see how does make an impact on the way you treat patients, maybe it's something that it can change it has been changing, but maybe it can change more in the following years, even though what I started saying, we have less time and more patients, so we have to figure out how to make everything fit in that short period of time.
I think you're muted, Dr. Senor.
Yes, I was muted, excuse me. I would go back to my previous statement. If you are a clinician and you are alone, don't try to be scientifically excellent. Just select few questions from existing validated questionnaires and use them. And use them for the care of some patients. And if you go to the Paris project, you will find some of the scientific articles we have been performing, explaining and validating very complicated, in a very complex way, each question of the questionnaire. So you can find everything there. But if you are a health center, if you are a service, the hematology service, you can make collectively a decision, and you can up this decision to your scientific society. I would say two things. Please do not invent. Don't try to make new PREMs and prompt questionnaires. There are a lot of them. Use the ones that exist, and please use the ones that others use, and you will be able to compare. So they are very basic things, but I think it's doable, and I think it's also very important to say that this is not so new. Doctors and nurses do that every day. I think nurses ask patients 2 or 3 times a day, how much pain do you have? So that's a problem. So try to keep it as a center of your practice, as we are doing, and make it more systematic, I would say, and talk more about that with the patients and with your colleagues. Yeah, I think you are completely right on the need of more time, but this is crucial time. It's time for making patients' need at the center. So try to use less time possible, not so much scientifically sounding, but at least useful. That will be my advice.
Okay,
and I have to say that I'm a senior researcher. Today I'm not acting as that, but yeah, I'm that.
Okay, thank you. And you have been, Dr. Sunil and Dr. Ivan, for example, Dr. Sunil, you've been like speaking directly to, the medical professionals. You've been, for example, telling them that, we've been using this, for a while. You've been asking about levels of pain and so on. But in terms of mindset, do you think that healthcare professionals, they need more support when it comes on to incorporating these tools, and like how can we support them? Do you think maybe trainings are needed and so on? I would love to get your opinion on that as well as Dr.
Ivan. Well, I mentioned that we need to see that invest of time and effort makes a change. Obviously, gathering information about your priorities and setting goals makes a lot of sense. We have to find a way how can we be supported by ITs integrated in the electronic health records, because in the end it's information for the treating physicians and the rest of the team. Only the way you gather the information, it may change the answers. It's completely different if you provide the answers in the waiting room, nobody's looking at you, and you feel free to answer whatever. Or if somebody's in front of you asking you, the way you ask, it changes the way they answer. No? Are you feeling all right? Is everything okay? You are okay, right? So yes, 3 ways of asking questions may have different answers just because what you are projecting, and yes, because some patients may feel that which is the right answer I need to give. So we need to find a way where physicians get the answers, that they are neutral, efficiently provided, and IT should help somehow to gather that information, especially because during the clinical visit, maybe you start speaking about what the patients wanted to know first, and that changes everything and changes the answers. Should be something that at least in the clinical trials, it's mandatory to be provided before you have any contact with the investigator team. So I think that we need to be trained, we need to see the point of it, and we need to get some help from IT to integrate it if we really want to in the electronic medical health records.
In my opinion, the key challenge for this is the interdisciplinary work, because once you put patients in the center, you confront with situations that you cannot handle as a nurse, as a doctor, as a social worker, things that you have to confront together. And I think that's, to me, the main challenge. Of course, it's very important to have IT support. That's, of course, crucial, as you said. But I think the issue is, what do we do when we know that the goal would be to go to the wedding of his daughter, for example? How can we help on that? What's the pain issue? It's the transportation. It's the issue for, I don't know, supporting to climb the stairs there, whatever, mobility issues. So the issue is that what, in my experience, changed life is that once you are confronted to this type of approach, you have immediately to go to interdisciplinary team and to work together with the patient on the solutions. So for that, some of the professionals don't find any problem because they went to clinical practice having that in mind from the beginning. They just wanted to do that. But for others, it's more difficult because they have been more years of compartmentalization, and that makes more difficult to do that. I think for the patients, and of course you can tell us better than us, it's very important that the professional is concerned with these issues and know that, and use the patient as a leader of how can we handle that. But this is another way of practicing, and as you said, it takes time, but it's not completely new. It's the reason why a lot of professionals enter to the field. So for some professionals it's very easy because it's the way they are practicing. For others it will be more difficult. But I think if we talk about that in our scientific sessions, in our clinical sessions, we put this discussion there, the situation will be easier. Also in the scientific societies. I would love to have that in the congresses we have.
Okay, thank you. And you guys just spoke heavily about like the participation of patients going beyond, for example, data collection. For example, Dr. Sonyol, you said in like, for example, co-creating like the solutions. And I wanted to get like your opinion as well, Lucia, all of your opinions on like what do you think participatory models could look like for the integration of these proms and prems, whether from co-creation, and I think Dr. Andrews, she spoke about this heavily too, so looking at co-creation, data analysis, and so on. What do these participatory models look like for you? And Lucia, you mentioned feedback earlier, so you know that could be.
I think it's tricky. I'm not sure who said it before that, you know, the ones that come forward are the ones that are activated, they're already engaged. I would say they're not the problem, right? You want to make sure you're hearing the voices of the ones that don't come forward, right? So in like the hemophilia example, you're going out to look for the ones, and then you hear the doctor saying next to me the question of time and everything that's on the table, and we experience it in the consultations, right? There's so many priorities, there's different perspectives. If you have the perspective of the carer and the child in addition, right? Like, and then the data collection, which has to be done in the right way, because we talked about more the prompts, but the patient experience part, you know, you have to be in a neutral setting. I mean, I could never, I mean, we've been in so many encounters where I was scared, my husband was scared, we were all scared to even ask a question. So it would be very tricky to, in that setting, to be giving, you know, feedback that is not biased, right? So I think you you need to think about these different aspects. And so I don't know if I'm answering exactly your question, but I think it's a multiple. There are multiple issues, so we can discuss more, whichever is.
Well, I think the patient's engagement is crucial. They need to understand why they are answering all those questions, and having feedback on not just at the end, if you can provide a groupal vision of the rest of the patients, what have they answered, where am I compared to them, or where am I compared to myself 3 months ago. To provide that feedback, it would be, I think, very important for engaging the patients, because if they don't know why are they answering those questions, it's difficult to go on. It happens in clinical trials. Something that we like to do is when they participate in a trial, more than obviously is his or her main interest to receive a treatment that can work. But at the end of the trial, to tell them, to explain which were the results of the whole trial, it's very well evaluated. So somehow making a parallelism with it, to have feedback on the rest of the group, more general vision on how have been prems and proms, and obviously they have made an impact in services or department and organizations, is something that patients would engage them to keep on providing those answers, that information.
Maybe if I can add an example, because this is from actual reality where we were sitting in the waiting room. This is already here in Spain, not in the UK. And before every single visit, we got an iPad and we filled out. I filled out tons of questionnaires, and then my daughter filled out tons of questionnaires, and this happened session after session after session. And I thought, I mean, okay, and they were relevant questions too, some more, some less, because as you say, over time things change, and as you, especially children and young people, like there's the developmental stages. And I did at one point enter the consultations, and I said, I'm really sorry, like I'm committed, I will fill this in, we have time in the waiting room, but what are you using this for? And it was great, the doctor did say, like, if the treatment no longer works, that you're on and your daughter is on, eventually will you use this data to make the case for another type of treatment? And in addition, he said a few other things. But I thought, how many patients have filled this out that they never heard? Like, why? What's done with it? They never seen some kind of a chart or some kind of a graph to see, okay, I filled in, my daughter is well, she's going to school, okay, has she, I kind of know. But so I think that's just in terms of the example, and I think what you said, that work with us, explain, and I think, are we eager to? Yes, in the right time when it fits in the lives of, and I think all of you here are patients, it's not just, or carers in some way or another. So I think we all want to take part if it makes sense and it's meaningful and it's used.
Dr. Senil, would you like to add?
Just very briefly, I think at this time there are people that want to involve others with have some reluctancy and professionals that have some difficulties, but I think the main challenge is to involve vulnerable patients. Vulnerable patients are patients that are different from us. They have probably a different health literacy. They perhaps don't understand us. They have perhaps a severe illness that can not allow him to make some decisions or have some efforts. So I think here, yes, we need a lot of training and special programs for that. And of course, as you were saying, time and resources. I think we have to think in a different chapter when we are thinking in vulnerable patients. And this requires, I think, a lot of organizational issues that perhaps are not so crucial when we are talking about, well, we say an average patient, just that.
Okay, and I do have a few follow-up questions, but I think now is the time to maybe open to the audience to see if you have any questions that you'd like to ask. And you can feel free to ask in Spanish. We have a very capable translator here, and Sophie. Okay, sure.
Hi, yes. So it has been talked about the patient experience, but I would like to ask if it's also being monitored also in terms of well-being, the social circle of the patient and how it affects the well-being of the patient, and especially if it happens with those patients that for variety of reasons they don't have such a rich circle of people that can take care of them and can take care of the people that take care of them.
And I'll bring a personal example, which I think when they take into account your entire life, you feel it. Usually it's not the case. And I think the reason I also went professional in this direction, because repeatedly I felt, you know, I have my husband, I have my family, I have friends, right? And you're connecting all the different dots. But I came across tons of families who had children with multiple conditions, disabilities, divorces, socioeconomic challenges. So I think it's the parallel maybe with the flower and these social determinants, or all these other determinants we have in life are extremely important. We constantly have to juggle our professional life, to school. We educate our entire environment about the condition. So, you know, I think it's another whole elephant in the room that you have to think about it. Like when we worked with the providers, we told them, we need you out there, not just in your hospital, right? Like we travel through the care system. You know, there's the school, and in a way the outcome is for an adult, whether he's able to or she function and go to work. For our child, you know, is she or he, are they going to school? Do they feel well at school? And the model that worked for us, when the professionals and the providers opened up, you know, it's not money, it's not the lack of solution, it's a mentality change, right? To say, okay, we work as a team, we exchange emails or phone numbers with the teacher, you know, with my employer, with the team, and you first think, oh, because it's the boundary, and I don't know where you said that you kind of have to, as if you're a professional, you have to protect yourself. You know, you have this day to day. But I think at the end, professionals also said that they saved time, they saved admissions. You know, they were improving really the outcomes that were mattering to the family. So, yes, the broader environment is absolutely essential, and especially trying to get to the hard-to-get groups, right? Like, why did they not come for a visit? Why are they not at school? Why are they not at work? I mean, there's whole realities of these families that matter.
So getting gestora de casos or something. I don't know, a coordinator we call here in Catalonia, gestor de casos, something like that.
I mean, from our experience, the families become the coordinators, but getting help, and I think it came up here, right? If the carers or the patients get help, we try to make it easier. But usually from the stories you hear, whether in adult care or children and young people, is that someone in the family ends up doing that. I don't know if it's realistic, but yes, there are these roles. I don't know enough good examples where maybe others do.
Well, I think it's a balance between obviously when you're in a visit, you are trained to identify who's going to take care of scheduling and so on. But I think it's something that patients cannot be passengers on that. They need to control. Obviously, they will have the help of their family and friends, but they have to take into account their control, self-management. It's encouraging them to keep track of when do they have to go to visit who and why. Obviously, they're going to be surrounded by family and friends in most of cases. And as I've said, you identify who are you. You are speaking to a patient, but when it comes to when you have the CT scan, you are going to direct your side to the person that is controlling that part. But encouraging patients to take control of the situation is empowering them for some of the aspects of the illness that I believe that it's important as well. So obviously, we always try that they can come with somebody else, because sometimes they are overwhelmed during the visits, and at the end of the visit, they haven't understood nothing about what you have explained, and they need some time, and it's especially useful when they are accompanied by somebody that can tell them what have the doctor said and so on. And it's something that obviously you have to work in the following visits. If that's not the case, if you are not surrounded by friends or family, there are some patients organizations that can help with to get with you to the visits, and obviously the help of social workers in some other cases where there all the issues are crucial as well.
Thank you.
In the meantime, I can add that it's good that the families make the coordination, but I'm not sure that is the best, because I think the system must do that. Donna Vivian used to say that the main quality problems happen in the intersections between primary healthcare and hospital, between hospital and home, between home and the school. So it would be nice if we have a coordinating system and don't give all the responsibility to the families that had, of course, they have a main word on that, but I think it's too much responsibility to think that the families would do that, and that will help, because delays are one of the quality problems more important in the system. So this is something that we have to have an internal system to do that ourselves as well.
Okay. Thank you. We've come to the end of our time and we've gone over quite a bit. So I think thank you for your insights. It has been a good discussion. We'll now have a break until 12:30. Okay, thank you.
Thank you for having us.
Thank you.